Good afternoon, and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. Today, we welcome Dr. Inma Hernandez, who is the Senior Advisor to the Administrator for Drug Prices at the Centers for Medicare and Medicaid Services. She's a pharmacist by training and is committed to improving transparency in drug pricing and reimbursement. At CMS, she's made significant contributions to the Trump administration's most favored nations deals and has assisted with the Inflation Reduction Act's Medicare drug price negotiations. Welcome, and we're excited to hear from you today.
Thank you. Very happy to be here.
So to get started off, a lot of our viewers are early in their careers and they would like to be like you someday. So how did you get to this point? And could you talk a little bit about your career path?
So I grew up in rural Spain, and actually my mom is an independent pharmacist and my dad was an economist. I went to pharmacy school in Pamplona, which is known for running of the bulls. And it was always a big dream of mine to come to the States for my PhD. I liked research, but I think it was clear to me that I had many limitations in the wet lab environment, but I always liked the population health approach and I always liked math and numbers. So I thought that a PhD program in public health would be a much better fit for my interest and also my abilities. I did my PhD in the University of Pittsburgh in a group that did a lot of work on the early days of the Medicare Part D program. And then when I graduated, I took a faculty job also at the University of Pittsburgh School of Pharmacy. I was privileged to have a very supportive environment, and I was able to start growing up my own research program, which eventually became a bridge a little bit between pharmacoepidemiology and also health services research and pharmaceutical policy. A few years ago, I got recruited to go to the University of California, San Diego. And obviously, San Diego is a difficult place to decline. So I decided to move across the country and joined UCSD also on the faculty. I'm currently on leave from my academic appointment at the university in service to CMS.
Great, thank you. And can you describe your current role as Senior Advisor to the Administrator for Drug Prices? What does the role entail and what kind of responsibilities do you hold?
Let's take a step back and talk a little bit about how CMS functions. CMS has an office of the administrator and then has different centers that tackle specific issues. So we have a center for Medicare, a center for Medicaid, a center, the CMS Innovation Center, and then a center that takes care of the ACA program. There's some issues like drug pricing that are cross-cutting across centers. So basically my role lives in the office of the administrator and I help with the drug portfolio across all of those centers. I work mostly with the Center for Medicare on the Inflation Reduction Act program and on the CMS Innovation Center on new payment models around drugs. But basically it's meant to be cross-cutting across the CMS portfolio with a narrow focus on the topic of drug pricing and drug spending.
Thank you. And there's a lot of different initiatives that we've heard about coming out of the Centers for Medicare and Medicaid Services relating to drug pricing, like the Inflation Reduction Act, Medicare drug price negotiations, the most favored nation deals, and various CMMI models like the generous model. Can you explain how these are different from each other or how they work together?
There's a lot of initiatives coming out because we are very busy here at work. I really like the question because I realize that we're putting out so many things that it can create confusion. Okay, the IRA is a process that is statutory, is run by our career staff, and is completely isolated and extremely differentiated from anything under the MFN framework. So as I said, the IRA is run by the Center for Medicare career staff following the guidance that has been set up based on the statutory requirements. The MFN framework is a little bit broader, and basically it was described in the letters that the president sent to manufacturers in July. The press secretary walked the press through the letters, so you can read them. They are in the public domain. Basically, the MFN framework is asking manufacturers for 4 requirements, for 4 commitments, and those are the following. The first one is Medicaid MFN, meaning making drugs available to Medicaid state agencies at prices comparable to other countries. The way how that piece is operationalized happens to be the CMMI generous model. So in brief, CMMI generous model is one of the 4 arms of the MFN framework. The second piece of the MFN framework is the direct-to-consumer or the direct-to-patient platform that we have been announcing, where manufacturers will make drugs available at highly discounted prices directly for patients to purchase through that pathway. The third one is a commitment to launching new drugs at prices that are not higher than prices in comparable countries. So that's the prospective piece. And the last pillar is what we call like the share savings or the revenue repatriation. And basically the idea is that if, thanks to the support of US trade policy, manufacturers are able to increase prices of existing drugs overseas, they will share part of that increased revenue back to the United States. So in brief, we have an MFN framework that is broad with 4 pillars. The CMMI model is one of those. And then, as I said, this is completely separate from the IRA pathway.
Great, thank you. So let's dive deeper on some of those. So let's start with the IRA, or the Inflation Reduction Act, and Medicare drug price negotiations. Can you give us a preview of what's expected to happen for 2028? And that will be the first time, if I'm correct, that drugs will be eligible for renegotiation. Can you tell us a little bit about how drugs get selected for renegotiation also?
Yeah, so there's a few changes on the 2028 guidance that was finalized a couple of months ago. And maybe I can walk you through them, and then we can get, if it's okay, to the point of renegotiation. So one piece is that for the first time in 2028, when we publish the list of negotiated drugs, we will also publish the list of other eligible drugs on the top 50 that didn't make it to the selection of 15 because of lower spending, but that would have been eligible otherwise. This is one of the initiatives that we have with the idea of improving transparency around IRA. Then an important change between the original guidance and the finalized guidance related to the inclusion of Part B drugs is that we will factor in both fee-for-service claims and Medicare Advantage expenditures in the selection of Part B drugs. This is something that the agency got a lot of comments last year, and we revised it based on the feedback. There's also a change related to orphan drug exclusion and the timing of selection of drugs that have orphan designations for negotiation, and that is based on the statutory change that came along with the Working Families Tax Cuts Act. So that is also in the new guidance, lots of things there. And then, as you mentioned, 2028 will be the first time where drugs that have been previously selected for negotiation will be eligible for renegotiation. So that is also described in the guidelines. Basically, we're thinking of the following. There's basically 3 categories of renegotiation eligible drugs. The first one is drugs that have changed monopoly status, meaning that they may have been short monopoly status earlier, and now they have a change based on how long they have been on the market. These drugs are required by statute to be renegotiated. Then there's 2 other buckets of renegotiation eligible drugs. One is drugs with a new indication, and the other one is drugs that have a material change to one of the negotiation factors. Among these groups, CMS will select drugs where basically there's an expectation that renegotiation will make a difference, that it will likely result in a significant change to the negotiated price, to the maximum fair price. How we are thinking about this is twofold. First, CMS will think what's the likelihood that the renegotiation may result in an MFP that has a change that is 15% or greater. And then the second point is whether actually that change on the MFP would have a significant impact on the program. So quite a little bit of a new process to think through in the next few months. But I will flag that the drugs selected for renegotiation will be announced along with the 15 drugs newly selected for negotiation next year by February 1st, if I got that right.
So there's some drugs that are fixed dose combination products, and that's really two drugs in one. Can you describe how CMS treats those drugs now, and have they considered changing their approach to those kinds of drugs for 2028?
So CMS to comment on the approach to fixed combination products this year in the 2028 guidance. And the final guidance says that we intend to address this issue in rulemaking for initial price applicability in year 2029. So I think this is something where there may be change coming in that rule.
We got a question from the audience that seems it's right on this topic. So do you have thoughts on the 2027 negotiated prices and how they compare with what was able to be negotiated under the most favored nation deals?
Yeah, so the 2027 negotiated prices will be out by the end of the month because that's our statutory requirement. So I think there's only 11 or 12 days left on the year, so they are coming out soon. As of how they connect with MFN prices, as I said, both processes are completely different. There's no overlap, and there's no connection with the MFN prices. The MFP, the IRA program is run by our career staff following the statutory requirements, excuse me, and the MFN prices are connected with the MFN framework that I described with those 4 pillars, but there's no relationship between them.
Thank you. So let's talk about the MFN or most favored nation deals a little bit more. In the past 2 months, the Trump administration has announced agreements with 5 pharmaceutical companies to bring most favored nation pricing to American patients. In the White House announcement on November 6th regarding the deals with Novo Nordisk and Eli Lilly, Secretary Kennedy thanked you for your extensive work in these negotiations. Can you talk a bit about these deals and what this might mean for reducing drug prices?
So the deals that were announced with Novo and Lilly are within the MFN framework that I described. It so happens that those deals have a few additional provisions that relate to GLP-1s, but these deals fall within the same framework of the Pfizer deal, the AstraZeneca deal, and the EMD Serono deal. So for drugs of those 2 manufacturers that are not GLP-1s, manufacturers will commit to the 4 pillars of the MFN framework that I described. Medicaid MFN, direct-to-consumer discounted and MFN prices, commitment to prospective most favored nation, meaning no launching here at higher prices than overseas, and then the share savings or the revenue repatriation. That applies to non-GLP-1s. The GLP-1 class obviously has very different dynamics because the drugs have not been covered by Medicare for obesity. So there was a little bit more complexity in that piece. I know there were many prices announced, so I'm going to try to revamp everything and explain where we got. So let's start perhaps with the DTP price, the prices at which these drugs will be available in Trump Rx. We will start with injectable GLP-1s at $350. That is a substantial reduction from the current DTP prices now, which are on the $500 range. And these prices will decrease over the next 2 years to $250. Both manufacturers have oral versions of GLP-1s currently under review. If they are approved, the initiation dose will be at $149, and the rest of doses up to $300. So that is the DTP construct. And I know that there's a lot of numbers there, and that can create a little bit of confusion. Then under the announcement, under this framework, the administration negotiated the contours of how we will eventually cover GLP-1s in Medicare and Medicaid if states opt to do so. Obviously, the coverage of obesity in Medicaid is up to states' decision. But the framework we had is that manufacturers could voluntarily decrease prices to $240 per pack. And that is inclusive of the copay, meaning we do not add $50 on top of the $245. $245 is the net manufacturer price. And that will apply to both the obesity formulations of these drugs and also the formulations that are approved for diabetes and other currently covered indications. The decrease in those formulations that are currently covered from the current net price to $245 will pay for the expanded access for obesity. So we thought this was a financially responsible way of expanding coverage through a negotiation that is enabled to bring some price concessions in factoring in how to expand access. Medicaid state programs will be available to access the same prices, as I said, if they opt to expand coverage consistent with the access criteria that was negotiated. This has been announced before, but I will just revisit. So the access criteria for obesity will be individuals that have BMI greater than 27, that means overweight, and either prediabetes or established cardiovascular disease. Established cardiovascular disease is defined as per label a history of a stroke, history of myocardial infarction, or peripheral artery disease. Then for individuals with obesity, meaning BMI greater than 30, the coverage will be for individuals that have kidney disease stage 3A or above, uncontrolled hypertension, or HFpEF, meaning heart failure with preserved ejection fraction. That is meant to mirror the evidence currently in the literature around clinical outcomes of these drugs. I will note that uncontrolled hypertension is defined as having a blood pressure reading above 140/90, regardless of being on two concurrent antihypertensives. And finally, the last access criteria is BMI greater than 35, and that does not require a comorbidity. I know, Jim, that I went through my list of details about that deal, and that's probably a lot of information. I'm happy to revisit any of that or make any clarification.
No, that's exciting, and I think that that's a really good explanation because we know in the Social Security Act that Medicare Part D was prevented from covering drugs for the purpose of weight loss. So that really explains how the GLP-1s are being used to treat underlying conditions and not being used just for weight loss in a way that's consistent with the statute. Let's move over. In that same press conference, we heard about TrumpRx.gov. Can you tell us a little bit about what the vision for that is, and will consumers be able to order their medicine through that website?
The idea for TrumpRx is that it will be a platform where patients can access the discounted prices that have been negotiated as part of the MFN framework. So it will be a landing place where patients can basically write the name of a drug and find the lowest available price that will include the direct-to-consumer prices that have been negotiated with manufacturers as part of our conversations and negotiations with them.
So are they able to order is it able to fill prescriptions and send it to my house, or is it more like a coupon where if I see the price on there, if I go to the pharmacy, I can get guaranteed that I can get that price?
Manufacturers retain the flexibility to choose the platform of their choosing for the dispensing. So that will be depending on the drug, how manufacturers have laid down their distribution and supply chain. But TrumpRx will be the landing place where patients can access all of those discounted prices. And again, then how the prescription is filled may depend based on how manufacturers have set up their distribution chains.
Thank you. And do you know, I think they said it would be live by the end of the year, but do you have any information on when the discounts will actually be available through TrumpRx?
We are working towards that. I think we said no later than January 1st. So I'm hoping it will be by the end of the year, but we don't have a date yet.
That's super helpful. I think that covers all the material that we had. Before we close, I'd like to ask you, is there one thing that you want the audience to take away from our discussion today? And if there is, what would that be?
So obviously we have multiple work streams within the administration around drug policy and drug pricing. And I realized that from the outside, it can get quite confusing. I think the main thing is that the administration is working very hard to deliver lower drug prices to Americans. I encourage you to directly read the sources of information that we put out to try to navigate what is going on. And always happy, my inbox is always open to answer any questions.
Great. Well, thank you again, Dr. Hernandez, for joining us. That brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you for sharing your expertise and insights on drug pricing policy. And before I close, we've just sent a message in chat which links to subscribe to our monthly newsletter and to visit our Northern Virginia Health Policy Forum website for more in-depth analysis into current and potential future health policy. Thank you for being here and enjoy the rest of your day.